Good afternoon again. This is Lynn Shaw with the Association of State and Territorial Health Officials, and you're on the ASTHO CDC webinar, Preparedness Planning for Older Adults with Cognitive Impairment. So thank you again so much for joining us this afternoon. And as you may notice, all participants are on mute, but if you have a question, please feel free to type it into the chat box. And then at the end of the webinar, you can press *7 to unmute your line, as we'll have a question and answer period at the end of the webinar. Also following the webinar, we will send everyone a link so that they can access the PowerPoint presentations as well as the webinar recording. So we have quite a full agenda today, so we are going to go ahead and get started. First presenter we have is Dr. Linda Anderson. She's the Director of the Healthy Aging Program, Division of Population Health at the National Center for Chronic Disease Prevention and Health Promotion at the Centers for Disease Control and Prevention. And we will go ahead and get started.
Yes, good afternoon, and thank you, Lynn. On behalf of CDC's Healthy Aging Program, I'm very pleased to provide a brief introduction to the session today. So one of the things I wanted to talk about or make you aware of is CDC's Healthy Aging Program has a program to address brain health. And we were appropriated funds in 2006. This effort was supported by really, as most of you know, there's an increasing population of older adults, both in terms of the numbers and proportion. We also know that there's documented concerns by the general public about memory loss in general and Alzheimer's disease in particular. And given the factors that I've just talked about, there's an increasing recognition of the need to address caregiver issues. And this is an important related topic to the preparedness agenda. And as part of our efforts at CDC, we were particularly concerned about the vulnerabilities of older adults during emergencies. My colleague Maggie Moore, who is really the leader at CDC on preparedness in older adults, really began to take an effort in this work when the hurricanes led us to recognize the unique vulnerabilities in older adults. And as you can see on this slide, there are a number of reasons in the first column. They're all health-related, and those are things that CDC is most likely to address. And you can see in particular cognitive impairment is one of those vulnerabilities. In the second column, this includes a number of contextual issues and why you'll hear today the importance about partners across many sectors, and particularly at CDC with the Aging Services Network. And while we included issues around preparedness in our first roadmap, which was released in 2007, really when we began to develop the new roadmap in 2012, we really wanted to include a focus on states. And so while our roadmap was independently developed, it's really linked to a number of national efforts, including the Alzheimer's Project Act, as well as the National Plan to Address Alzheimer's Disease, including the 2014. And when we developed our roadmap, we used a process called concept mapping, which is led by a 15-member leadership team. But it included input from over 280 stakeholders. And there are a total of 35 actions that the public health community, particularly at state and local levels, can focus on over the next 5 years. And it includes 4 important domains really related to the core public health functions: monitor and evaluate, educate and empower the nation, develop policy and mobilize partnerships, as well as assuring a confident workforce. And one of the key action items focuses on preparedness, and it is related to the policy function, which talks about integrating cognitive health and impairment into state and local government plans, particularly those related to preparedness as well as aging. It also includes in the roadmap a number of important actions that are being taken to consider dementia in terms of preparedness planning, and I've given an example of one of those on this page. And related to really these efforts, CDC, in partnership with a number of organizations, have developed a guide called Identifying Vulnerable Older Adults and Legal Options for Increasing Their Protection During All Hazard Emergencies. And this is really focused on community dwelling adults aged 60 years and older. It includes a number of strategies and options, one to characterize the population using GIS, using registries, or looking at shelter intake. In addition, there is an extensive web portal that looks at a compilation of existing information, resources, and tools. These have been extensively tested by users during their development, and it features a number of tools such as models of memorandum of understanding, a number of PowerPoint presentations that you might find helpful, as well as model injects specific to older adults, and the web link is on these, and these slides will be provided at the end of this presentation. So with that introduction, I want to turn it over to the next speaker. Thank you.
Great. Thank you so much, Dr. Anderson. And next we have Dr. Melon McBride. She's the Associate Director Emerita of the Stanford Geriatric Education Center at Stanford University School of Medicine. Dr. McBride, please remember to press *7 to unmute your line. Hi, Dr. McBride, we still can't hear you. Can you press *7, please?
Okay?
Okay, yes, we can hear you now.
All right. Sorry about that. I kept pressing, it seems like. Good afternoon, and thank you very much to ASTHO and CDC for this opportunity to participate in the Healthy Brain Initiative program. And my learning objectives on the next slide will focus on objective 1 and 3. The second one, Betty is going to speak about that. And the next slide lists the 3 Healthy Brain Initiative action items that our presentation broadly relates to. And the next slide, here I wanted to share with you an ancient Chinese parable about a monkey and a fish who were good friends. They got caught in turbulent waters, and the monkey managed to grab a branch. Then he grabbed the fish to save his friend. The lesson learned here is one needs to understand the nature of the fish. So most of my slides have information specific to ethnic, racial, older adults, with or without cognitive impairment and their caregivers, that are important for building partnerships with diverse populations for planning and executing emergency preparedness. And the numbers that you see here on the slide would, of course, be one of the support for the importance and urgency of planning emergency preparedness. And the next slide.
Hi, Dr. McBride. I'm sorry to interrupt, but we're hearing from a couple folks that are having trouble hearing you. So if you could get a little bit closer to your phone, that would be great.
Okay. Am I better now?
Thank you.
Okay, the next slide, which is what's on the screen now, highlights some health needs that create challenges to older adults when under stress. And Dr. Anderson mentioned that health issues are one of the considerations in preparedness planning. Those of you who have direct contact with older people may have seen a few of the situations. For example, an otherwise healthy-looking older person who becomes dehydrated and ends up in an urgent care clinic. Someone who already has mild cognitive changes are at risk, and when dehydrated and a disaster occurs, could trigger a reversible disorientation. The next slide. There are situations such as those listed here that require special communication strategies. When cognitive impaired seniors from diverse ethnic backgrounds have sensory issues that may heighten their fear of authorities due to past experiences as a war refugee or having been removed from home as children and taken to the boarding school, like many American Indian children who are now older adults, may also connect this with the experience of being asked to move to an evacuation center. So the next slide are indicators of increased vulnerability of older persons. And in particular, I have highlighted the substandard housing, racial, ethnic identity, and having a pet, some of the risk factors for older persons, especially when mandatory evacuation is in progress. And those who have pets may be concerned about getting separated and would prefer to shelter in place. And they may not be prepared to do that, or they can't do that since it's a mandatory evacuation. Excuse me, the next slide. In 2007, the Centers for Public Health Preparedness concluded, after studies of post-disaster recovery, that when resources are stretched thin, the needs of vulnerable populations are left unmet in all phases of preparedness. So allocation of scarce resources in planning emergency preparedness suggests that preventing vulnerable or at-risk populations from falling through the cracks require their participation at the decision-making levels, at all levels, from the local to the national level. The next slide, there are several of these slides that are socio-demographic slides about older adults aged 65 and older. And this first one is a projection for each group, which shows all groups are expected to increase in varying rates towards the year 2050. Asian Americans, in particular, who are culturally diverse population, a very culturally diverse population, are projected to have the largest increase by 2050. So planning ahead now for emergency preparedness need to include language services for those with limited English proficiency as one important consideration. There are others, but this one is probably a very important one. It's already been mandated as a federal law that public agencies should have language services for their patients or clients. So the next slide is a graph that simply indicates that at Stanford GEC, the increase in its population group that are culturally and linguistically different from each other, their health needs and aging experiences are part of the Ethnogeriatric imperative. As mandated by HRSA that supports geriatric education centers, our center devotes its resources to provide ethnogeriatric training and has been a resource at local, regional, and national levels. And the next slide provides a graphic definition of ethnogeriatrics, and it also shows the areas of knowledge and expertise that contribute to ethnogeriatrics as an evolving specialty in aging. Looks like some of the letters got squished, through on that screen. And so most of our training are interprofessional or interdisciplinary, multidisciplinary training. The next slide highlights living arrangements for these different population groups. Living arrangement is critical to planning emergency preparedness for elders with cognitive impairment. Their caregivers are key to the seniors' safety. Note that Asian elders tend to live with other people. They're one of the lowest rate percentage of living alone. So they tend to live with their immediate family, extended family, and friends. Teaching and helping them with emergency preparedness would involve other people. And making contact with the various groups would start with places they go to, such as local, social, civic, nonprofit organizations, churches, businesses, local media, schools, and other organizations in your neighborhood or in your community. The next slide identifies that Asian American elders and Latino, Hispanic seniors would need language services to be safe, secure, and to survive in a disaster. So that language services, both as an interpreter or a translator or written materials, would be an important component of their preparedness kit, personal kit, or information materials in a shelter, for example. So the next slide is about a report in 2010 that found poor outcomes for people from diverse communities, especially those who have language issues. And it's important to note that this is a report in 2010, so that this issue about language continues to persist at this time. The next slide presents the conclusion that functional needs of ethnic elders with dementia fall under various classifications of vulnerability, and at present, partnerships with researchers is critical to have scientifically sound, evidence-based interventions for the subgroup of ethnic elders. And it's also the need for more epidemiologic studies for these groups, because there's still very little information about dementia, Alzheimer's, and other types of dementia for these different population groups. The next slide will focuses on beliefs and attitudes that have been uncovered through a focus group studies. One is a dissertation on American Indians who live in Maine, the Passamaquoddy tribe, and a nonprofit legal agency had a focus group with Vietnamese, and the Somali community living in Maine participated in a focus group that was part of a doctoral student's dissertation. And so there are many different ways to get information and continue to develop insight on the different population groups. For example, with the Passamaquoddy, they still have profound distrust for formal systems. So we have a lot of work to do in terms of trust building. And the Vietnamese group, there were some concerns about law enforcement personnel, and the African immigrants from Somali who are still living with their painful memories about life in the refugee camps are still very much part of their belief systems and attitudes towards formal systems. And Dr. Kleinman, in the next slide, a psychiatrist proposed that human beings have explanatory models that come from our beliefs, values, experiences, which influence us when we interact with our environment, especially with formal systems. And he studied this and has shown that there are certain experiences that carry on through time and may just be popped in at one point when an ethnic elder may be in the process of dealing with a situation, such as perhaps an order for evacuation. So at SGEC, in the next slide, we developed a concept called cohort historical analysis and cohort historical experiences, where we adapted content, knowledge from anthropology, social sciences, and psychiatry tool for teaching and for patient assessment as part of social history taking. We gain insight on an individual, family, or community when we understand certain significant historical experiences that live with us over time. The Holocaust, for example, is one example, and there are others that are listed here on the slide. And I do apologize for the text that do not seem to be following the format, and I think maybe it's perhaps the size of the slide that's shifting those texts. So I'm sorry about that. I hope that when you are downloading the slide, this text will align itself automatically. So our next slide is a very interesting occurrence because we have had our usual model of emergency preparedness, that it's CDC and FEMA have been very active in emergency preparedness and responding to disaster. And there is now a paradigm shift in 2011 when the national approach to disaster preparedness shifted to the idea of and theory of whole community inclusion and community resilience. This slide provides you with links to resources and briefly and partnerships with the entire community, local, regional, and national levels. This came out of the realization that disaster preparedness is the government's responsibility. However, a resilient community would be a stronger position to handle an event and recover sooner when the community develops or enhances its resiliency before an event occurs. An example in communities is the CERT program. Maybe many of you have heard of this. This is the Community Emergency Response Team. And they are volunteers in the community who take training on preparedness. So it's been found that those that have CERT programs in their community tended to be more resilient during and after an event. And so this is one great partnership when developing programs for elders, ethnic elders, and other elders with dementia or Alzheimer. Families and caregivers for elders with dementia could be encouraged to take the training in their community. and then they become part of the network that would strengthen and sustain the resiliency of the community. The next slide is legislation that everyone is very familiar with back in 1964, the Civil Rights Act. And at all levels of the Civil Rights Act, this has been an important tool for ethnic communities to participate in improving and increasing access to health care and information that help them to ensure safety for seniors with dementia and their caregivers. Another initiative in the next slide is the standards for culturally and linguistically appropriate services. This is currently overseen and addressed by the Office of Minority Health, and there is a link to that if you want to know more about it. And planning or evaluating emergency preparedness plans would use the guidelines to address language concerns as well as all the other mandates of this standards. There are 14 standards. A new concept has come into the scene, and the next slide, we have all heard about cultural competency, cultural proficiency, and now a new concept called cultural humility has been introduced as another step for service providers to take towards developing skills in working with clients, patients who are from a different culture. Basically, the provider who may be designated in the workplace as a first responder can receive training to help understand and value other cultures. And the goal is to develop a certain level of understanding, and this falls under the umbrella of cultural humility. This concept is being slowly entering some academic programs. Some medical schools have incorporated this concept. And at SGEC, we include this concept in our faculty training. And faculty come from different parts of the country, and then they go back and infuse some ethnogeriatric concepts in their training. We also have this available on our website, so you'll be able to see a webinar that we had given on cultural humility. So the next two slides are examples of potential partners for planning emergency preparedness for diverse older adults and their caregivers. The Alzheimer's Association has two members on our panel today, and you'll hear about their specific partnership from their experience. And in this slide, the La Raza, which is a Latino organization, would be one of the groups that the CDC or the local public health department could partner in working with emergency preparedness plans for their community, for the Latino community and the elders with dementia. There's also the Asian Pacific American Legal Center, and there's the link to it. And there is also a Center for Disability and Health Policy that have developed interest in being active in the field of preparedness, emergency preparedness. So the next one, the last one, is I wanted to just let you know that the geriatric education centers are HRSA funded, and there is an organization called the National Association of Geriatric Education Center. Within that, we have a group, about 6 geriatric education centers have formed a collaborative for geriatric emergency preparedness, and we have been in existence now for over 10 years. Our mandate is to provide training in emergency preparedness for elders and different sites, long-term care, hospital, community. And the different GECs are listed on this slide. And so SGEC and Betty's GEC, which is the OVAR GEC, is a member of the collaborative. And if you are interested in what we do and you need some information about training, please feel free to contact us. And so thank you very much for this presentation, and I hope that, that's my picture, Christine.
So thank you very much, Dr. McBride. And that is who you just heard from today. And next up we have Betty Shields. She's with the University of Louisville Kent School of Social Work, the Kentucky Emergency Preparedness for Aging Program, and the Ohio Valley Appalachian Region Geriatric Education Center. And Betty, if you could please press *7 to unmute your line.
Is that working?
Yes.
All right,
perfect.
great.
Thank you.
Let me talk about the scope of cognitive impairment in long-term care and how it relates to state and local public health planning. Nationally, there are 1.6 million persons living in long-term care. The prevalence of cognitive impairment across this population from a diagnosed point of view is approximately 60%, and undiagnosed takes that number, the prevalence, up to 80% of persons living in long-term care have some form of cognitive impairment. And there are a number of types of cognitive impairment, and what's important about that is not the name so much as the fact that not all forms of cognitive impairment evidence the same symptomology. So knowing and understanding that there are multiple forms of dementia and cognitive impairment also informs the type of symptomology that we are likely to see. And this can make it difficult in terms of screening tools in a shelter situation without significant testing of the instruments to be sure to cover the various forms of cognitive impairment. Dementia care in long-term care is daily practice. Given the prevalence numbers, there is no staff in a long-term care facility that I can think of who has not received good solid training in working with those residents, much less is experiencing ongoing training. There is a move at the federal level to reduce the use of antipsychotic medicines among persons with cognitive impairment living in long-term care. And so the emphasis has moved from psychoactive medications to behavioral interventions. And as such, the expertise required to manage persons with cognitive impairment without using anything but a minimum of psychotropic drugs becomes almost an art, as if it wasn't art enough. Pre-planning is the key when working with persons with dementia for disaster planning. Given the prevalence, given the seriousness of the degrees of cognitive impairment within long-term care populations, pre-planning is absolutely critical. The last thing long-term care needs to be doing, or the state or the local public health units need to be doing, is waiting for the disaster to provide an incentive to plan. Sheltering in place for long-term care is always a first choice. The vulnerabilities that Malin spoke of earlier about elders and about ethnic elders also pertain to persons with cognitive impairment living in long-term care. Evacuation historically puts evacuees, long-term care evacuees, at risk for severely negative outcomes ranging from increased health care conditions to death. All long-term care facilities have shelter-in plans already in place. So respecting that, acknowledging that, and finding out what those range of plans are, I think is an important point of view. In terms of local and state public health response, supporting long-term care functioning if they are in a shelter-in-place situation is a number one focus, or should be a number one focus, because if we can keep them in the facility with staff, with familiar surroundings, with access to their personal belongings, their medications, their rooms, the less agitation long-term care residents will experience, the less wandering risk they'll experience, the less falls risk that they'll experience, and the better everybody will be able to manage that emergency. Working closely with county emergency management is very important, even in a shelter-in-place situation, because if it's serious enough, the facilities may need access to additional water, to power supports, to fuel. If their fuel is running low on their emergency generator in a power outage situation. Supporting an active medical reserve corps initiative in your area is also of vital interest because of the potential for a shortage of nurses and CNA staff in a facility, depending on the barriers, the tangible barriers that might be in the way, from tree limbs to high water rising to the earth opening up. And we had this example just earlier today with another sinkhole has opened up in part of western Kentucky, and there's a personal care home that's having to evacuate as we speak. I've been on the phone and on email earlier today about that. Needing pharmacy support is also a critical element, working with and planning for long-term care and their disaster preparedness and a state and local response. The typical long-term care resident takes a minimum of 8 prescription medications a day and in multiple at multiple times. So we're not talking about simply giving meds 8 times a day. We're talking about 8 different meds with medication distribution times throughout the day. Partnering with community mental health is very beneficial for the facility, for staff, for management, for families, as well as the residents. And then lastly, working with your area agencies on aging who have great expertise and incorporate your state long-term care ombudsman programs in terms of assisting with patient tracking, as well as other patient, resident, and family-related issues. The shelter experience with Hurricane Katrina has taught us more than we would ever want to know about the risks and vulnerability of persons with cognitive impairment, especially evacuating from long-term care. Medical records were not able to accompany the long-term resident evacuees to their shelter sites or to their alternate care sites. They had to evacuate so quickly, and in many cases there was no time at all to incorporate their medical records. Long-term care staff accompanying residents is probably your best tool, because those staff know those residents and their needs and their unique circumstances, as well as how they can best be managed in that stressful situation. And you'll have a much more effective evacuation experience if long-term care staff is accompanying residents. Persons with cognitive impairment may not be able to express their needs. They may have language issues. They may have lost the ability for language. They may have hearing impairment. They can be sight impaired. They oftentimes are unable to ask for their basic needs to be met, and that puts them at greater risk of death from lack of care of chronic conditions. We certainly found this out of the research from Hurricane Katrina. The majority of persons who died in shelters were over the age of 50. The majority who died suffered from chronic conditions as opposed to hurricane or flood-related conditions. And their care could have been ameliorated to the degree that they would not have died. So organization and pre-planning, whether it's a shelter environment, whether it's an alternate care site environment, is indeed critical. Shelter management needs of persons with cognitive impairment, especially evacuating from long-term care, need to be considered. Because of the preponderance of long-term care evacuees with cognitive impairment, their sheltering environment needs to be in a secured area with locked doors and security at each of the doors, so that anyone leaving or coming into that part of a shelter is indeed monitored and acknowledged. Persons with cognitive impairment, especially living in long-term care, have a tendency to wander. And in the midst of a catastrophic event, you could be dealing with more golden alerts than you would ever want to. And it also makes very bad press. Environmental safety for cognitively impaired evacuees is important because of their high falls risk, the mobility barriers that they have. Quiet areas and low lighting is very important for managing persons with cognitive impairment, especially long-term care evacuees, in a sheltering situation. So having long-term care residents in a medical needs shelter versus a special needs shelter or a general shelter is very important. They need to maintain their schedules. They need their sleep schedules, or everybody will pay for it the next day. They need quiet areas during the day as well as during the evening so that their stress levels are minimized. The likelihood of agitation, which can ultimately lead to wandering, creates additional stress and simply exacerbates an already difficult situation. Having a great activity planner or a great activity plan in a shelter situation is vital in terms of a long-term care population because of the propensity of residents with cognitive impairment. And then having trained volunteers available, whether it's to work with a medical needs shelter, long-term care evacuee population, or even in a general needs shelter or a special needs shelter, because ideally the recommended ratio is a 1-to-1 supervision or volunteer connection with somebody with cognitive impairment in that type of an environment. Areas of synergy at the local level include working with your federally funded hospital preparedness program, healthcare coalitions. We've been very successful in Kentucky. We have 15 regional coalitions that are the most successfully operational coalitions I have ever had the experience of working with. These include county emergency management, emergency medical services. All of the hospitals have representatives. Long-term care administrators are represented, and or long-term care subcommittees. We have a number of those in our regions. Having a county health care surge plan, including hospitals and long-term care, should there be a need to surge from hospitals or long-term care to other health care facilities in a medical emergency. At the local level, know your state emergency operations plan as well as your county plan, because the two tie together, and it won't be long before a county emergency rolls up to become a state level emergency. Having a solid county mass care plan also is important so that it's clear where long-term care evacuees are likely to be sheltered and understanding what the implications of that would be. Collaboration is the key, whether it's at the local level or at the state level. At the local level, public health departments need to have relationships with the long-term care facilities in your counties and in your districts. Have relationship with your county emergency managers. Know them by name as well as by face. Again, know your state emergency operations plans. Know what preparedness partners are already in place. If they're in place and they've been functioning for a number of years, Please don't try and recreate one, because if you've got a functioning coalition or a functioning partnership, there's a lot of assistance and support you can offer instead of trying to create something that's parallel. Also, recognize that long-term care has regulatory barriers which get in the way of them being able to respond to sheltering either other long-term care in an evacuation situation or special needs populations. And knowing what those long-term care regulatory barriers before you create a special needs sheltering plan will really assist the effectiveness of your plan. Keep in mind that long-term care utilization rates at the national level run 83%, and here in Kentucky they run 90%. So on any given day, a typical long-term care facility in Kentucky may only have 8 to 9 available unfilled licensed beds. And the amount of extra space for placing persons in non-sleeping areas continues to get smaller and smaller as utilization of those spaces is increased by other activities and other needs. Again, supporting long-term care in staff and getting to the shelters and surge sites is a key way that a local public health can help, and having good sheltering plans for pets so that family pets will have a place to be settled, as well as sheltering family members of staff so staff can be ensured of showing up for work.
Hi, Betty. This is Lynn. Just as a quick time check, since we have one presenter left, if you could wrap up in the next minute or so, that would be great.
I will wrap up.
Okay, thank you so much.
For evacuation and sheltering, differentiate between whether your state is in advance notice type of an emergency state or if it's a no-notice state. Here in the Midwest, we get an average of 13 minutes notice in advance of a tornado. Our primary risks are immediate risks, whether it's a thunderstorm, flash flooding, or landslides or earthquakes. So if a facility evacuates in the Midwest, they evacuate because of an emergency, not in advance of an emergency. So vendor contracts may not be sufficient. Why is that important? Because you're going to need to put into place your mass casualty plans, your transportation plans, have resources available from all of your ESF8 partners, because in that type of situation, long-term care will not be able to take care of themselves. Long-term care staff are your experts. This is a list of key partnerships. I think it's self-explanatory. You can check it on your slides. And if you remember, nothing else, don't plan for long-term care without long-term care at the table. Thank you.
Thank you so much. And next from the Alzheimer's Association in Oregon, we have Sarah Holland and John Bartholomew.
Hey, can you hear us?
And thank you.
Okay, great. So I'm going to go through this relatively quickly because we've heard a lot of the stuff that we were, wanting to talk about has already been covered by a lot of the great presentations we've already heard. So thanks to all of those folks who presented already. So what we want to talk about is actually collaborating at that local level. As part of the work that we're doing with the Alzheimer's Association is to really take the Healthy Brain Initiative to the local folks doing public health work. And so the first thing that you got to always consider is looking for those likely partnerships who have similar goals, but maybe different skills or resources that they can bring to the table. And for those of you who, I'm sure you all recognize Oscar the Grouch, the other folks, the other beast there is Grumpy Cat, and as they are different in some ways but also have certain things in common, Alzheimer's Association and the Public Health Division for our state also, we have a lot in common. And we want to stress that you can find these kind of common partnerships anywhere in the country. Alzheimer's Association has chapters all over the United States that has resources to bring to bear to help those folks dealing with Alzheimer's in emergency situations. So the first thing that you need to look at when you're doing a partnership, at least that we did, was to consider what is already in place. And the reason this is so important is because so many of our organizations and public health departments have limited resources, they're stretched thin. So the goal is to make things easy to do, like work the anything related to cognitive impairment into existing efforts. So we looked at what's already happening, and there's Public Health Association conferences, there's planning processes, there's Public Health Week, and how do we get involved in what is already happening that the state and the counties are already doing. So the goal is supporting existing disaster preparedness initiatives as well. So here in Oregon, we have kind of a decentralized system where the state does a lot of information provision, but a lot of the action really happens at the county and local level. And that's probably similar for disaster prep in most parts of the country as well. But so we work with the state in getting that information out to all the county folks. And this is particularly important in Oregon. We just heard a great presentation on doing things in that long-term care community. Oregon has a system set up that is geared to keeping people in their own homes much longer, and so making sure that the community response teams, emergency response teams, really have the information they need, because there's going to be a lot of folks living in their own homes with dementia as well. So the first steps that we've taken, and I would note that we have a lot of work still to do. It's early on in our partnership. But the first steps were to provide information. So working with the All Hazards Coordinator in the Public Health Division to provide information via the internet, website links related to cognitive impairment and emergency preparedness. We're working with them on adding a section to their Ready Book that's provided to those community emergency response teams in each county, so that there's a go-to section that they have. We are sharing quick tips for first responders, which is a particular document that the Alzheimer's Association provides, with coalitions or other organizations that are in the same line of work that, for example, the Oregon State Sheriff's Association, the Association of Chiefs of Police, Oregon Public Health Association, the Coalition of Local Health Officials, making sure that they have these materials in their hands. And we also were able to put together a presentation for Public Health Week this year, and Sarah will talk a little bit more about that as well. And again, there's no need to reinvent the wheel. The materials exist to provide to the public health professionals and volunteers to be able to use. You had already seen one of these earlier on in the presentation, and there are other materials that you can get from the Alzheimer's Association and from the CDC. So I'm going to turn it over to Sarah to talk about the presentation that she did with our All Hazards Coordinator at the state of Oregon.
Thank you, John. So just as John was mentioning, we were looking for opportunities where we could layer in information to what was already happening in the state of Oregon, both at the state and county level. So for this particular presentation, it happened in our state public health building. We knew that they were going to be public health professionals who focused on that state picture, and we wanted to make sure that everyone that came into the room had understanding of what dementia is, what is cognitive impairment, what is Alzheimer's disease, and how do they all fit together. We wanted them to understand how prevalent it is within their own communities and how significant a problem it can be in the situation of a disaster. And framing it again as this public health issue, this idea that it's something that needs a macro intervention. And then specifically drilling down to what are the things that within the context of disaster preparation that you should be thinking about and things that you can do, resources that are already in place. So we thought about it from this systems approach, challenging the people in the room. So if you're working on disaster prep already, how does dementia fit into the work that you're already involved in? How does it fit into this planning for these evacuations for situations where people are all in one place? Or, as John mentioned, we really need to be discussing in Oregon when people are in the community and are in the middle stages of the disease, possibly even early late stages of the disease, how are we supporting and providing information to these individuals and their families? So when we began talking about what can we actually do about dementia and disaster preparation, we emphasize personal preparation efforts and really including that when we're talking with family members, caregivers in the community about what can you do to make sure that you are as prepared as possible in the event of some sort of disaster. Looking at training first responders, both professional first responders and then those that are volunteers. On the coast of Oregon, we have quite a few retired individuals who are first responders in the case of a tsunami. So that's a group that's pretty active already around education. So how can we layer training and education into what they're already engaging in? Talking with nursing homes and residential care regulators, and considering the special needs while sheltering. So what coalitions, what groups are already meeting and discussing these issues. And then we specifically highlighted the long-distance caregiver, which for many of our families, they are carrying long-distance, helping someone manage the disease from a state away, from a town away. So how does that impact the individual who is in that situation where there is a disaster? So right now, some of the next steps that we're looking at in Oregon is that we want to include a dementia and cognitive impairment information in the toolkits that are already being distributed throughout the state. There's a training for first responders that the Alzheimer's Association has had for several years, and it has a disaster prep section that really goes into some great detail on how do you recognize dementia, how do you communicate with somebody, what are some of those safety protocols that you can put into place. And this training will actually be online and free sometime this summer so that any first responder, whether professional or volunteer, can take that section or any number of sections that have to do with the dementia and Alzheimer's component. And then the next thing that we are working on doing with our state coordinator is developing a training specifically for caregivers, helping them put together all those things that they should be thinking about in the case of a disaster. And this would be a brief training that we would initially pilot in support groups where we already have people kind of converging and having conversations about the issues that they're facing as caregivers.
So, thank you very much, and hopefully other chapters of the Alzheimer's Association will be contacted by some of you to help out and work in coalition.
Great. Thank you so much, John and Sarah, and thank you to all of our presenters and to all of you for being with us here this afternoon. Again, as a reminder, we will send the slides as well as the recording later this week. And if you have any questions, to be respectful of folks' time, we're going to go ahead and adjourn the webinar. But if you have any questions, please don't hesitate to email or call me, and I will direct it to the right person. And thank you again for joining.
Thank you.